Hey guys, so this guy, he essentially completely passed out and went into respiratory failure. I mean, he was literally going into respiratory failure, and when he's getting increasingly agitated, I tell people all the time, asthma plus agitation, be concerned. Be ready for the worst case scenario. That's them completely going apneic and potentially in cardiac arrest. And that's what this guy ended up doing with me is he took his last breath and went into cardiac arrest. Um, One thing that I did was, which wasn't the greatest thing, was tried to keep putting a mask on him, and he was fighting it. So now, not only is he at a point where he is so oxygen starved that he is so anxious, he's trying to make sure to get in a little bit of breath in and fight off anything that he feels is stopping him from doing that. That takes more oxygen to do, right? It takes more to get to fight it off than, and he doesn't understand because the way he feels he doesn't think that the oxygen's helping him or that he thinks this would actually suffocate him. So that was like the big thing. When you approach these people and, in the end, this is a small snapshot, a little bit of information, not a whole lot. It gave you the key features to be able to make decisions, hopefully. And the biggest thing is, some of the questions that we brought up. How do we oxygenate somebody who won't take it? I mean, obviously, it'd be a good thing if you get oxygen on them, maybe even CPAP if they take that, but some are just going to push you away. So you got to figure out a way to get oxygen close without making them feel like they're being smothered. So coaching them into that is obviously a pretty big deal. At what point does respiratory difficulty become respiratory failure? And literally, you're compensating, you're having difficulty breathing, your body's telling everything to ramp up a little bit, increase rate, increase heart rate, increase respiratory rate, increase depth. The idea there is that your body's going to try to compensate. Well, you get to a point where your body can't compensate anymore, and then so when we begin to fail to compensate, we're no longer having difficulty breathing, but we're failing to compensate, and so our SATs will start to drop, and our end tidal will start to get bigger and bigger, and they'll separate. Right? That is literally when we have an increasing end tidal, lowering SATs. That's respiratory failure. That's when we need to step in and do something. So either call med control. If you have the ability to RSI, that might be a time to do that because they most likely are going to get worse. If you could intervene and get them to consider using a CPAP or BiPAP and putting that on them to see if that, because that could be a great bridge, but they get all bent out of shape and they do this, and then boom, they can collapse. So be ready to act on that is one of the biggest things too. What information do you need to choose between EpiDrip or MagDrip later down the pathway? I mean, again, this is asthma, so we want to make sure that we're giving albuterol, maybe even a duoneb, so we're adding atropine, that ipratropium bromide, two different mechanisms that open up airways. So you have albuterol, and then you also have atropine. Solumedrol, or basically a steroid, it's not going to help in your transport unless you're going to be with them 6 or 7 hours. It happens about an hour or two later. It'll start to reduce the swelling in the airways, but not a bad thing to consider. But it's not going to help immediately, so we'll just work that into it. Let's see, we have albuterol, solumedrol, epi. I mean, giving a dose of epi IM so that one might be ideal for this patient. He's fighting you off. You need to open up those airways so he can breathe and exhale. So maybe a little IM epi, maybe even IV epi, but IM might be a good idea. So get epi on board, open that up. Once he goes down the rabbit hole, now you're bagging for him, and now we need to open up, make sure we're opening up those airways. You can do it with an EpiDrip or MagDrip. Both of these will open up airways, but the question is, which I didn't give you, is blood pressure, but that's the question, is ultimately, when do you give mag, when do you give epi? If their blood pressure is good or high, then maybe you consider mag, because the mag's going to drop their blood pressure a little bit. But if they have enough blood pressure, then maybe they can hold that. If their blood pressure is low, well, then epi would be a good choice because it's also going to increase blood pressure. So thinking of it that way, like what's really going on and what's our medicine going to end up doing, will really help you in making some of those choices and changes. It's an airway thing also. I mean, not really directly airway. The system is the lungs that's the problem, of course. But epi opens up airways, increases pressure, just helps out all the way around. So, but mag is also a great drug for bronchospasm. Terbutaline was something that you could consider. So go through and look those medicines up, and the biggest thing is if you have a concern, if you have a anxiety with asthma, please, 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 please make sure that you're paying attention to that. So my guy died, and I didn't act fast enough, and I was a very young medic, and it sucks. We did all the stuff, we just didn't get him some of the other things that he really needed, and really sad. And hopefully you learn from my mistake, and that's the big thing: asthma, and not only anxiety, but asthma and increasing anxiety is what the nurse said. Make sure that you're thinking about that and then acting, really expeditiously. So anyway, hope you enjoyed this case. Hope you did better than I did.